Hey guys, welcome back to Medicine Deconstructed. I'm your host, Dr. Jay Rutland. First of all, I want to say thank you to everyone I have a lot of new subscribers. I really appreciate that. For those of you that have left comments and feedback, I appreciate that as well. I am trying to tailor the channel to what you guys want and what you guys want to see. Lately, we've been focusing on coronavirus, more specifically, SARS coronavirus 2. I'm going to talk about things that we know, and I'm going to talk about specifically today what I would do and how I would manage SARS coronavirus. I'm going to talk about how I would design a clinical trial. All of you know I trained in academics, but I do not currently practice in an academic institution as much as I would love to. So let's think about this. Let's think about SARS coronavirus and what happens once you inhale this virus. This virus is going to travel down your trachea. It's going to bind in your lung, more specifically to the type 2 pneumocyte, which has the ACE converting enzyme receptor type 2. Once it binds to that type 2 pneumocyte, the immune system recognizes that something is within your lung that is foreign. The macrophages in your lung that reside within your lung start to secrete a cytokine called interleukin 6. They also probably secrete MCP3, interleukin 1, and other types of cytokines that lead to the rush of T cells and NK cells into the lung. This has been proven when you look at the bronchoalveolar lavage fluid in addition to looking at lung biopsies. We can see that T cells and NK cells are present within the lung. Now, once your immune system gets activated, if it gets overactivated, you're going to go into what's called the cytokine storm. As I've mentioned previously, cytokines are basically recruitment molecules of certain white blood cells. Once the white blood cell recognizes something foreign, in this case, the SARS coronavirus type 2, it starts to secrete cytokines. More specifically, when you look at the cytokines involved in this condition, we're talking interleukin 1, MCP3, IP10, interleukin 6, interleukin 2, amongst others. And there are cytokines that are, when they're produced, they actually signify worsening disease. And those cytokines include interleukin 6, MCP3, IP10, interleukin 1RA. Now, since we know that the immune system is extremely activated, that leads to the recruitment of cells into your balloons, right? Your lungs are essentially balloons that receive air from pipes. When those balloons are full of white blood cells instead of full of air, what happens? You're really short of breath and you cannot gas exchange. So the immune system's active. We also know that these patients tend to coagulate their blood. They tend to have more blood clots and microthrombi when you look at the biopsies of these patients. They will develop small pulmonary embolisms. Now, there's a certain percentage, and it's a significant percentage of these patients, so physicians have decided to anticoagulate based on certain parameters, and I think that that's important. So when you look at this condition, just like with any other condition, there are multiple ways to attack it. And I think that we, as a healthcare society, need to start thinking of multiple ways to attack this condition. Because typically what happens, and the way that we're training, is we all look for one. We all look for one thing that's gonna fight this one virus and help us get over this one virus successfully. Here's the thing. We all know, physicians included, that it takes multiple modalities of therapy to help someone improve to a certain point with many diseases. This disease is no different. So if I were designing a trial, I would use 3 different modalities of therapy in these types of patients. Again, the median time to hospital presentation for COVID-19, which is the disease that SARS CoV-2 leads to, the median time of hospital presentation is day 7. The median time to ICU presentation is day 8. So you basically have 24 hours to know how severe someone is going to be. So this is the way that I think. If someone with SARS coronavirus 2, once they present to the hospital, you know they're already severe. So if I were to design a trial, what I would do is I would start attacking this condition right away, and I would use the 3 treatment modalities, which I would do right now. If I were performing a trial, I would use an immunomodulating therapy Specifically, I would use an IL-6 inhibitor, interleukin-6 inhibitor, interleukin-6 secreted by macrophages upon the existence of the virus within the lung. Those medicines include sarilumab, tocilizumab. I would also use a viral RNA polymerase inhibitor. Those molecules include remdesivir, ribavirin is one of those as well. Then I would also anticoagulate. Maybe not full anticoagulation, maybe half anticoagulation. I think for us, what we typically use when someone has a pulmonary embolism is we're going to use Lovenox 1 milligram per kilogram twice a day. In this case, based on maybe a TEG or based on someone's hypercoagulability, I would use Lovenox 0.5 milligrams per kilogram twice a day. For reasons that I cannot explain, we always think because we're in the hospital all the time and we're used to seeing sick people, we support them and we may not give them the treatment that leads to resolution, or we may not give them the treatment that we actually think would lead to significant improvement. We wait and see. And if somebody does worse, then we activate that treatment. But I think with COVID-19, once you present to the hospital, you're already severe. Those cytokines are already going. How do you know that? Because the patient that presents with COVID-19 is presenting because they're short of breath, they're having fever, and they're having significant symptoms, likely secondary to the cytokine storm. What do I think is important moving forward? So a lot of people, a lot of physicians will say, well, if you start someone on an immunomodulating therapy, you're going to lead to them not producing as much antibody. Who knows whether or not that's true? What I would do is I would look at the patients right now that have received tocilizumab or sarilumab, and I would test their plasma to see if they have made or manufactured antibodies towards SARS CoV-2. If they had, then that thought is wrong. They're still making the appropriate antibodies to be able to neutralize that coronavirus infection. So again, for me, what's important to me is once a patient presents to the hospital, they're already severe. They've already demonstrated severe symptoms. So it's important to act quickly. So I say what we should do and what we should design clinically is a trial that includes remdesivir, a viral RNA polymerase inhibitor, tocilizumab, an interleukin-6 inhibitor, and some anticoagulation. We should use this moving forward, and we should study this and see if patients improve, to see if it leads to less ICU admissions, less intubations. That's the kind of thing that needs to happen for us to move forward. It's hard to just choose one therapy and see if it has an effect in a disease that affects many different types of cells and leads to many different types of complications. As we think about COVID-19, understanding the cytokines that are extremely elevated in that illness, which include MCP3, interleukin-1RA, and IP10 or CXCL10, the reason why I'm focusing on these three cytokines is because those three cytokines are the ones that are most associated with significant respiratory failure. They're the ones that are most associated with ARDS. Now listen, in this illness, COVID-19, it's not typical ARDS, all right? People have defined ARDS a certain way. And again, what I always say is that ARDS is a process. It is not really a differential diagnosis. It's really just a process. But speaking on that further, when you look at those three cytokines, one of the cytokines that I think is most important is IP10, otherwise known as CXCL10. This specific cytokine leads to the recruitment of T cells into the lung and is most associated with an ARDS, or T cells within the lung. When you look at 4 other illnesses and ARDS and worsening PF ratios, the presence of this cytokine means something. The higher it is, the worse the ARDS. Those other 4 illnesses, H1N1, H5N1, SARS CoV-1, and MERS. Remember, SARS CoV-1 and MERS are the other severe human coronaviruses as well. So what do I think? I think that when you look at IP10 and CXCL10, inhibiting this cytokine may have a significant effect on a patient developing ARDS. Fortunately, this medicine already exists. It's called eldelumab. and they've used it and studied it in ulcerative colitis. The studies weren't very positive in ulcerative colitis, but I would ask this one question. There's a certain percentage of patients that have ulcerative colitis that do develop interstitial lung disease, my favorite disease. I would ask the question of, the patients that were in this trial, what percentage of them presented with respiratory failure to a pulmonologist or to a hospital? If none presented, and we know that people do develop respiratory failure with ulcerative colitis, that should tell you something. I think this medicine is future. I think this medicine should be studied next. Eldaluumab, just pay attention to it. I just read a lot. That's just my suggestion. That's what I think. That's the way that I think, the way that my thinking has developed as a result of being interested in immunology, as you guys all know, as it pertains to interstitial lung disease. And to me, COVID-19 is basically interstitial lung disease that is rapid and on steroids. That's how I look at this illness. I appreciate you guys joining me today. Please stay tuned for future episodes on COVID-19 and other medical topics. Leave your comments, leave your feedback, and I'll see you next time. Thanks for joining today.
Cedric J.